question? Right, so if you have read and understood, considering each history taking station, kindly begin.
Hello, I'm Dr. Jatin, one of the exam candidates. May you
Good.
confirm your name and age, please?
I'm Sarah, 19 years old.
Hello, nice to meet you. So what brings you here in the hospital?
Oh, doctor, I'm having this serious pain on my tummy for 2 days. Please
Okay,
help me.
I'm so sorry to hear about that. It must have been very difficult for you. So can I ask you some further questions regarding your problem?
Sure.
Okay, when did you, okay, so can you please point me to the site where do you feel the pain?
It's actually the whole tummy, but more in the right side.
All right. So how it started, whether it is sudden or gradual in onset?
Yeah, it started suddenly.
Okay. So can you please describe your pain, whether it is sharp shooting, stabbing, colicky, or dull aching pain?
Yeah, it's sharp, colicky in nature.
Okay. So does this pain goes anywhere else,
No, it's
like to
around
your
it.
back or any shoulder tip? Uh,
No, it's just around my tummy.
okay. So apart from this, have you ever noticed any episodes of diarrhea? Or
Yes, I noticed there are 2 episodes of loose motion since yesterday.
okay. And can you please tell me the consistency of the stools, whether it is semi-solid or watery or
Yeah, it's more of watery.
okay. So was there any blood in the stools?
No, doctor.
Any slime discharge along with that?
Yeah, some slimes has passed.
Okay. So have you ever suffered from constipation?
Yeah, sometimes I have constipation and sometimes I have loose motions.
Okay. So
But more often I have loose motions than constipation.
all right. So have you ever experienced mouth ulcers or painful red eyes or muscle pain or joint pains?
No, doctor.
Okay. And have you ever experienced any unintentional weight loss or loss of appetite recently?
No, doctor.
Okay. Have you ever been to abroad recently?
No, doctor.
Okay. And have you ever experienced any episodes of fever or you are feeling any indigestion to the meals?
No, and haven't noticed anything like that. But I can't take food properly. If I take food, then there is an urge of passing stool.
Okay. So uh, have you noticed that your pain in tummy settles after passing the stools or flatus?
Yeah, more often after passing stool, there is a relief of my pain.
Okay, can you please rate your pain from 0 to 10, 10 being the worst pain you have ever imagined?
Oh, now it's around 7 to 8.
Okay, I'm so sorry to hear about that. And have you ever met the GP in the past for any other medical conditions?
No, doctor. Just for this reason, I have been visiting my GP, but it comes and goes on and on.
All right. So are you taking any medicines?
No, doctor.
Okay. Are you allergic to any medicines?
No, not known to anything.
Okay. And have you undergone any surgery in the past?
No, doctor.
Okay. So I would like to ask you some personal questions. What is your occupation?
I'm a school. I'm a student.
Okay. And with whom do you live at home?
My parents and sibling.
Your parents. Okay. So do you take alcohol
No, doctor.
and do you smoke?
No, doctor.
Do you take any recreational drugs?
No.
Okay. Is there anyone in the family having the history of cancer
No, doctor.
and is any history of inflammatory bowel disease in the family?
No, doctor.
Okay. So can you please tell me a little bit more about your health? Like, have you ever experienced any headache, dizziness, or seizures?
No, doctor. Just I'm feeling a bit nauseated during taking my meal. That's it. And this pain on the tummy.
Okay. So have you ever experienced any pain in your chest or difficulty in breathing?
No, doctor.
Uh, have you ever experienced any cough or wheezy chest or recent COVID symptoms?
No, doctor.
Okay. And have you ever experienced any uh, intolerance to fatty meal?
No, doctor.
Okay. And have you ever experienced any difficulty with your waterworks or bowel?
No.
Okay, thank you so much. Can you summarize your history now, please?
Yes, ma'am. 19-year-old female presented to me with the chief complaints of tummy pain and which she is experiencing from yesterday, and there are 2 episodes of vomitings. She is also having the altered bowel habits of diarrhea and constipation, and there is no history of weight loss, and there is no history of anorexia. There is no history of any fever. So my top differential will be, and there is a stool which is associated with the slime. So
So what
my
are your provisional and differential diagnosis that you're going
so
to consider?
my top differential would be inflammatory bowel disease, and my second differential would be irritable bowel disease or colorectal cancer or infective gastroenteritis.
What investigations would you ask for to confirm your diagnosis?
First of all, I would like to go for abdominal examination, and then I will offer the routine blood test, which will include the CBC, urea, electrolytes, KFTs, LFTs, and then I will go for the stool culture and analysis,
Yes,
and then ultrasonography of the abdomen
yes, abdominal ultrasound. Yes.
and CT abdomen and colonoscopy.
Okay, maybe not CT, just simple abdominal X-ray. Okay, what are the management options that you can offer to this patient?
So if I'm considering the inflammatory bowel disease, we can go for the medical management. I can offer her the medical drugs like mesalazine or prednisolone or immunomodulators like infliximab, and diet. I will low residue diet, and surgical treatments we can offer if the patient is refractory to medical management, or there is a toxic megacolon, intestinal obstruction, or there are fissures.
Okay,
So, or there is a malignant transformation, we can go for the surgery.
right. Thank you so much.
Okay, thank you,
Okay,
ma'am.
now my question to you is, I really enjoyed the way you took the history. It was very nice, very well structured. It was like you covered most of the questions, but some important points you left. But it was very nicely structured and it went very in a good sequence. So you have to keep this in your mind. These are your plus points. But where I have objection, and others will probably agree with me, right? Considering the young age, you made the first diagnosis, inflammatory bowel disease. Why in the stem or in this particular history, what made you think that the patient would be suffering from inflammatory bowel disease? You did ask for family history and you got the answer no. Even then, this was your first provisional diagnosis. Why? Please?
Ma'am, there was a slime
Yes, then,
in the stools.
yes, in which conditions you have slime? Now that means that you don't know inflammatory bowel disease and you don't even know the difference in irritable bowel disease. That's
Okay.
alarming. So please tell me. We are discussing. If you want, I can wait.
Ma'am, I don't actually.
Wait. I started your timer and here is your question. Right. So if you have read and understood, considering it communication skills session, kindly begin.
Good morning. I'm Dr. I wash my hands. Good morning. I'm Dr. Kolade. Can I know your name and age, please?
Yeah, I'm Harris, 32-year-old male.
Okay, thank you, Mr. Aris. Hope you're okay to call you by by Aris.
Yes. Okay.
Okay. I've been called to see you because of your surgery that was cancelled.
Okay.
My consultant, I'm one of the doctors working here under Mr. Man, the consultant that is treating you. We have an emergency trauma case, so he has been called to attend to the emergency. So that's why I won't be able to do your surgery. I want to apologize because of this. I know your surgery has been cancelled twice before. I'm apologizing. Please don't be offended.
No, you can't do this. It's second time. You can't do this, please. It's my day.
Sorry, Mr. Aris. This is because we have an emergency and we have to prioritize for the emergency over your condition. I'm very, very sorry because of this. Please have your seat.
Even my knee is an emergency. Please take care of my knee. I'm here. Okay. It's my day of operation. You can't even cancel this surgery. Okay.
Sorry,
Don't even
Mr.
think about that.
Sorry, Mr. Aris. This particular case is an emergency, is a life-threatening condition. So that's why we have to, my consultant was called to come and join the surgery. Unfortunately, he has started the procedure, is already in theater for the surgery. So that's why I won't be able to do your case today. I apologize that your case will have to be rescheduled.
No. Please call your consultant right now. I want to have a talk with him. Please.
I'm sorry, Mr. Reese, I won't be able to call the consultant now because he's already in the operating theater. He's busy operating, so I won't be able to pick the call now. Sorry about that.
Oh my God. Can I have some another consultant?
Okay, Mr. Reese, is your choice. I know it's your choice to choose whichever consultant that is going to treat you, but picking another consultant now may not be in your best interest. The new consultants will have to start reviewing your case from the beginning. and that may be actually time consuming. So we advise that you stay here with us, and then the next possible date of surgery, we will reschedule your case and do your procedure.
Oh, I can't wait for such a long time now. Can you operate? Even you are a doctor.
Yes, I'm a doctor, but unfortunately, I don't have the authority to do this procedure without my consultant supervision. So I won't be able to do the surgery today until his and apology for that.
Oh, can you please give me the next date now? Please do something for me, okay?
Okay, Mr. Harris, I will discuss with the consultant when he's done with the surgery, and I will particularly emphasize that we've rescheduled your surgery twice, and this is the third time that we are canceling it. So I'll give you a call back on the next available date that we plan to do your surgery, but you'll be one of our priority at our next available surgery day.
Okay, I understand this, but make promise with me. It should not happen next time again, okay?
It will be difficult for me to make a promise, Mr. Harris, because if we have another life-threatening emergency, then we may still have to prioritize that.
Okay, my employer is going to be very much annoyed from me. What should I do now? I'm not going to my job. I'm not even having my surgery. What should I do now?
So sorry about that. We write to your employer stating your medical condition. They won't be able to come to resume your normal duty now. And if you don't even mind, I can call him on your behalf and tell him the reason why you won't be able to come to work until after your full treatment and recovery from your knee injury.
I can't even walk properly. My knee is paining. My knee pain has increased a lot and it's deteriorating. What should I do now?
So sorry about that. And do you mind if I give you analgesics now? I should give you analgesics.
Okay.
Yes,
That's
so I'll
fine.
give you analgesics. Then because of your pain, I will advise that you don't walk for now. So you have to be on use your crutches to walk. But I will advise that you do exercises like swimming so as to strengthen the muscles around your shoulder, around your knee. And then I will also refer you to see the physiotherapist. The physiotherapist will tell you some exercises that you also be doing to make sure that the muscle around your knee is still active, so that you won't have a weakness around your knee.
Okay, doctor. So I can I ask you something?
Yes, you can go ahead.
I take diclofenac for the to control the knee pain. Is it safe?
Yes, diclofenac is safe, but if you're having any problem like it can cause heartburns or bleeding, then we have to stop it and then give you another analgesics that will not cause you those symptoms, those problems.
Okay, doctor. So can you give me a little bit of detail about the arthroscopy procedure which you're going to uh, arrange for me?
Okay. The arthroscopy procedure is like we put a small cut on your knee. We put our instrument inside. We'll be looking at your knee on the TV. So we'll be able to see the injury that has occurred, and then we can also repair those injuries and that you have while still looking at the television, that will be while looking at the monitor to do the procedure. So that's what the arthroscopy is.
But I'm not happy with this system. I want to make a complaint. What should I do now?
I want to really apologize for the problem and that we won't be able to do your surgery. I apologize to you. Don't be annoyed. We will put you as one of our priority at our next operation date. Apology for that. I'm apologizing on behalf of the consultants.
No, but I want to make a complaint. Can you please tell me what should I do now?
Okay, I will direct you to the complaint desk so that you can lodge your complaint. So we want to tell you that today I'm apologizing that I won't be able to do your surgery because we have a life-threatening emergency. Mr. Man, your consultant that is treating you has to attend to that so as to save the life of the person. We are going to get in touch with you on the next available date and prioritize your case. And I'm also going to let your employer to be aware that you are sick and you need more days on sick off for you to be able to do your surgery and undergo recovery. My contact is with the nurse in case if you have any other question, inquiry, or clarification, please get across to the nurses. They will call me. We are here to give you the necessary support, information that you need. Is that okay by you, Darius?
Okay.
All
Okay.
right,
Thank you. So where would you send the patient if patient wants to complain? What does it called? You did mention something, but you were not even sure.
Yes, I think, I'm not sure. There is a C.
Started the timer, and here is your question. Nice. Yes. Right. So if you have read and understood, considering it surgical anesthesia, kindly please tell me. Right. I don't expect you to identify the structures, but if you can, it would be very good. Can you tell me, after reading the stem, what injury might have taken place? Patient was, yes,
the patient may has
picking, when you're picking a fruit from a top branch, what kind of injury it causes? And it
yes,
leaves
it
the
may
patient in painful
Break-
limb?
brachial
Yes,
brachial plexus injury.
injury, okay. So if you tell me what are brachial plexus, how are they formed?
Again, please.
What is brachial plexus? How are they formed?
Yes, brachial plexus, they are a group of nerves. They are formed as formed from the trunks.
Yes.
Yes,
First, tell me the root value, roots C5 to T1, right?
yes.
Okay.
Yes,
There, what are the most common two injuries which occurs on brachial plexus?
herpes palsy and the Columbus paralysis.
Yes. Okay. If we assume that this injury is Erb's paralysis, if we assume this condition is Erb's paralysis, how can you tell me how or what would be the motor loss that you expect patient to suffer from?
There will be loss of abductor, and so the patient will come with
Yes.
abducted arm, and
Yes.
there is all loss loss of supinators and
And the arm will be adducted and abducted or
yes,
internally rotated.
and a loss of external rotator and
Yes. And how would be the
and
position of the forearm?
the forearm will be abducted, internal rotated, and
Forearm will be in extension and in pronation. So
extension.
which muscle spinators you already mentioned, and
Yes, loss of
flexors.
supinator and the
Flexors.
flexor. Yes.
Very good.
Yes.
And what would be the position of the hand?
Yes, the hand will be flexed.
Yes, in the waiter tip deformity kind of. Okay. So what would be the sensory loss that you expect to see in
Yes.
Erb's paralysis?
As there will be sensory loss in the radial side of the arm and forearm.
Very good. And the root value which affects or which is affected by in Erb's paralysis is which one?
C5 and 6.
Very good. Okay. If I can quickly ask you, you told me brachial plexus are formed by T5 to T1. So can you tell me in sometimes why are they called prefixed or postfixed?
Sorry, what? Why what?
Normally, brachial plexus is formed by root value C5 to T1, but sometimes it is called prefixed brachial plexus or postfixed brachial plexus. Why?
Prefixed or postfixed?
When it involves
No.
C4, so prefix. When it involves T2, then
Okay.
postfix. Okay, can you please tell me how the chords are formed of brachial plexus?
How the trunks?
Chords. Yes, after trunks, there are division
Yes.
and then chords.
Uh,
How the chords
yes.
are formed?
Okay, the trunk, there is the upper and middle lower trunk, which gives the upper and lower trunk, which gives the divisions, and there is anterior cord and as a anterior cord and the posterior cord, and the anterior cord is formed by the anterior division of the upper and middle trunk, and yes, and the posterior cord is formed by the posterior division of the three trunks, and the middle cord is formed by the middle division.
Yes. Posterior
Oh,
parts of all the chords, they forms the middle, posterior cord. Okay, can you please tell me how the chords are named? Lateral, posterior, and medial. Yes.
Yes. Lateral
Why?
cord and posterior cord and medial cord.
Yes. How are they named? Why are they named like this? Why are they named like this?
Because medial to the subclavian artery and lateral.
Because of their relation to the second part of the axillary artery. See, so that's how they are named.
Yes.
Right. So yeah. If you have to look at the hand deformity between Erb's paralysis and Klempik's paralysis, what are the differences?
Yes, for the hand in the Erb's paralysis, it will be hand tip deformity,
Yes.
flexed. While on the Columbus paralysis, there will be claw hand, there will be paralysis of the interossei muscles and the flexors of the wrist and the fingers, and there will be hyperextension of the metacarpophalangeal joint and hyperflexion of the interphalangeal joint.
Yes, and it is called Benedict's hand. Okay, can you please tell me how the shoulder girdle is formed? What is shoulder girdle?
Shoulder girdle, it's formed by the rotator cuff muscles. Sorry, the head of the humerus inside the glenoid cavity.
Yes, and then strengthened by rotator cuff and labrum. Okay, can you please tell me how the shoulder? Okay, you just told me shoulder joint. Can you tell me if you can identify two, please, over here?
Number what?
Two. Please. Here, two is
acromion procedure.
Okay. What is 10, please?
Spine of the scapula.
Okay. If you can identify 5, please.
Infraspinatus fossa.
Okay. What is attached over here, please?
The infraspinatus muscle.
Okay, right. 11.
Where is 11?
Yes, here. My cursor.
11, I can see.
Okay, can you please tell me 14, please? 11 is here, and then 14, please.
Yes, 11 is subscapular fossa. 14 is
What is this notch? Yes.
As a suprascapular notch.
Okay, good. Can you please tell me what are rotator cuff muscles? Or
Yes,
what is rotator? Yeah.
they are supraspinatus and infraspinatus and teres minor and subscapularis.
Teres minor and subscapularis. Okay. Can you tell me, okay, Bill has gone. Can you, okay, I want you to tell me what are the muscles or what are the factors or what are the contributing things which decreases the stability of the shoulder joint?
Yes, factors that decrease the stability of shoulder joint is the shallow glenoid cavity
Very good.
and also weak ligaments.
Yes,
Lex
and
ligament.
yes, lex capsule and weak ligaments. And
Yes,
third,
lex capsule and ligament, and also torn the muscles, torn rotator cuff muscles if the muscles are not
presence in quadrangular space.
and quadrangular space. Yes, the presence of
Yes.
quadrangular space.
So next question should be, what is quadrangular space?
Quadrangular
Boundaries?
space. It's bounded by superiorly teres minor, inferiorly teres major, and to the lateral is the surgical neck of the humerus, and to the medial is the long head of triceps, and
Okay.
it
Contents?
contents
Yes.
is axillary nerve and circumflex
Circumflex
humeral artery.
Very good. Last question, please. Can you tell me what are you looking at? Can you identify the image, please?
This is an MRI of the shoulder.
MR arthrogram of the shoulder. Okay, coronal oblique view. Can you please identify structures from 1 to 10?
Yes, number 1 is acromion.
Very good.
Number 2. Yes, number 2 is axillary vessels.
Yes. 3, please.
Number 3 is axillary recess.
Yes, of the shoulder joint. Very good. 4.
Number 4 is the clavicle.
Very good. 5, please.
5 is deltoid.
Very good.
Deltoid tendon.
6, please. 6.
6 is the labrum.
Yes, very good. This is labrum. Okay, 7, please.
Glenoid.
Okay. 1 is cavity and 1 is the labrum. Very good. Okay, 8, please.
Humerus, head of the humerus.
Yes. 9, please.
Supraspinatus muscle.
Very good. 10, please.
Supraspinatus tendon.
Very nice. Excellent. Good. Nice. Thank you.
Thank you.
Started your timer and here is your question. Right. So if you have read and understood, considering it critical care scenario, kindly please tell me, how would you manage this patient now?
Okay, I will manage this patient according to the critical care of surgical patient protocol.
Yes.
Okay, I will by which entails the ABCDE.
Yes.
I will I will check for I will check for the airways patent and then talk the patient, check for if the airway is patent, and then check the breathing and do assess if it excludes the patient has any pneumothorax or hyperresonance or dullness, and here for the chest, for the lung sound, and so for the chest sound, for the lung sound, and for the heart sound, and then assess the circulation of the patients by measuring the capillary fill time and the blood and the and blood pressures, and then start dealing with and assessing
Okay.
the central
Can
central
you
line.
please tell me, considering the scenario, what wrong has been done? What was wrongly done?
He has wrongly done that the patient has a central line which may be inserted which may cause trauma in pneumothorax or hemothorax. So
Yes.
the line, so
According
should,
to the NICE guidelines, how
yes,
central line should have been inserted?
according to the NICE guideline, it should
Yes.
be inserted under ultrasound, guided
Yes.
ultrasound,
Yes.
and we should do we should do X-ray after inserting for the
Yes.
to make sure that it is in that the central line is in the right space, and its tip is at the tip of the right atrium in the side of superior vena cava, and also to exclude pneumothorax.
Yes. So where do you expect to see the tip of the central line that you're inserting? In the superior
Yes,
vena cava, just superior to its entry in right atrium.
yes.
Okay. Can you please tell me what are the types of pneumothorax that you know of?
Yes, there is a simple pneumothorax,
No,
type of
first
pneumothorax.
simple. Yes, types of pneumothorax. So there is
Yes, there is
simple, and there is
simple and
tension
the tension,
or
and there
open.
is open vascular
Yes.
and closed.
So what are the difference, or what are the signs that you'll see in the tension pneumothorax?
Yes, the intention pneumothorax, there will be shifting the trachea, shifted trachea and the mediastinum to the
Opposite
contralateral
side,
side,
yes. And
the opposite side, and also the patient, there will be a respiratory compromise and the tachypnea,
yes,
and
yes. If you
um,
suspect that patient has tension pneumothorax, what
yes.
are the measures that you'll do immediately, instantly?
Yes, immediately I will after I will call for help and call for a cardiothoracic surgeon for insertion of needle thoracotomy in the second
Very
intercostal
good.
space,
Okay.
uh,
Yes.
mid-clavicular line, followed by chest tube in the fifth intercostal space, mid-axillary line.
Okay. As compared to simple pneumothorax, how management would differ?
Yes, and the
Then
simple.
patient's hemodynamics are more stable. In this condition, patient is having sharp chest pain and tightness around the chest. What do you suspect? Is the patient, on vitals you can also see, do you think patient is suffering from tension pneumothorax or simple pneumothorax?
Yes, in the patients, as the patient has a shortness of breathing with high respiratory rate, so he may develop tension pneumothorax.
Yes. All right. This was something you missed to tell me. Anyway, okay. Can you name few indications when central line should be inserted?
Yes, central line is indicated if for the total peritoneal nutrition, or for the fluid administration, or for for the dialysis, or for the cardiac pacing, or for
TPN?
yes, central venous pressure monitoring,
Yes.
and
right. Can you name a few complications of central line insertion, other than this?
Yes, related to the lines, there may complication like infection or thrombosis,
Yes.
or
Air embolism, maybe.
yes, or air embolism, or injury to the surrounding structure causing chylothorax or pneumothorax or hemothorax, and also
How
may cause
can
cardiac.
yes? what
cardiac
measures
tamponade.
can you take to prevent these predisposing factors from occurring?
As by following the NICE guidelines in inserting the central line under ultrasound, and by doing post-operative post X-ray.
No.
What?
These are associated with the procedure. But what measures can you take in order to prevent central line complications to occur? You told me infection and all those things can occur.
Okay.
So what can you do to prevent that happening?
Yes, I should.
Hygiene and all that. Tell me
fo-
those.
Yes, I should follow the hygiene according to the
Yes.
trust protocol
Yes.
by wearing gloves and apron and eyeglasses and apron and overhead, and also washing the washing the before putting the central line. The area
Yes.
should be the skin should be washed by an antiseptic solution and left for dry.
Yes.
To be dried, and then when touching the central line again, the hand should be washed with soap and alcohol,
Very good.
and
Yes.
and the central line should be removed if it is not needed. Should be removed as if it is removed early, this will lead
Very good.
decrease
Okay.
liability to infection.
Since this patient has shortness of breath, what are the 2 investigations that you'll do immediately?
X-ray and
ABGs.
ABG.
Yes, very good. Okay, can you please tell me what is the landmark of internal jugular vein?
Okay, internal jugular vein, it is just lateral to the carotid artery in a triangle between the two head of sternocleidomastoid and the mastoid process.
Very good. Okay. Right. Mostly I have asked you. Okay. What is the most common organism which might occur or which is found in patients with the central line insertions?
Yes, the phylococcal epidermis.
Very good. Okay. Right. What is the technique according to the NICE guidelines which should be applied while removing the central lines?
Yes, the head should be down to prevent embolism.
Very good. Okay. What are the few requirements or indications when you should remove the central line immediately?
Okay, it should be removed when if the patient no longer needs the central venous line, or he is discharged to the home, and also if if there is any sign of infection, and if
yes. When once you have stopped the cardiac support like inotrope, and when there is more than infection like sepsis.
Yes.
And acute situation has been resolved. Very good.
And if the patient has if the patient is will be discharged from the ITU to
yes. Okay. One last question, and then there is one slide. Okay, can you please tell me what you understand by the term safe triangle?
Yes, safe triangle, it is the site of insertion of the chest tube. It is bounded by anteriorly the lateral border of the trapezius and
pectoralis major.
Sorry, pectoralis major. Yes, pectoralis majors, and posteriorly by the
imaginary line. Which one?
No, I forget.
Mid-axillary.
Yes, mid-axillary line posteriorly, and inferiorly is a line drawn from the nipple backwards.
Yes.
And the apex is axillary.
How the safe triangle is different from adult to a child? Yes, it's a homework. We'll do that tomorrow. Can you please help me and read this image? But you see these
Okay.
3 arrows are pointing at what? What has happened?
Okay. Okay.
A, B,
This is an
C,
plain
D of the X-ray. Yes, please.
Okay, this is in a plain X-ray of the chest.
Yes.
There is regarding the airway. There is a shift. There is a shifting of trachea to the right side.
Yes.
Okay, shifting the trachea and the mediastinum to the left side.
Can you see there is tracheal deviation?
Yes, there is
What
tracheal
about the
deviation and
costophrenic angles on both sides? Comment on that, please.
obliterated post-costophrenic angle
On which side?
on
The left.
yes, on the
Can
left
you
side.
see the
Yes.
stomach in the chest and
This stomach and the chest.
okay.
Yes, it is the right. It is the tube.
Left? Yes.
Yes, it is
Can
the
you
stomach.
okay?
side.
What else? Can you comment on exposure? Can you see the vertebrae? Can you see what
Yes.
else? Can you see? Can you see the cardiac shadow? Is
Okay.
it there?
Yes. Regarding the airway, I can see the trachea and is shifted. And
Yes.
regarding the bone, the ribs are well seen.
Yes.
The cardiac shadow is seen and is shifted
Mediastinal
upwards.
shift. Okay. Then
Yes, and the
diaphragm. Yes.
diaphragm is there is elevation of the diaphragm by the stomach.
Can you see the gas under the diaphragm? No.
No.
Okay. Any extra because it's A, B, C, and D. D is exposure and anything extra, bones, soft tissues, any fractures, anything, any extra thing. How are the soft tissues?
You see,
Yes.
soft tissue. That's all. I think.
Yes, that's all. Right. Good. Thank you.
Thank you.
Thank you. Nice.